introduce you to my friend, Dr. Tina Costacou, and I'm pronouncing her name wrong. Please pronounce it for us.
Costacou.
Costacou. Okay, I've known her for a long time and I've always butchered it. I'm sorry. So Dr. Costacou is an associate professor of epidemiology at the University of Pittsburgh Graduate School of Public Health. She earned her bachelor's and master's of science at the University of Massachusetts Amherst, and her PhD at the University of South Carolina. She did a postdoctoral fellowship at the diabetes epidemiology at the University of Pittsburgh. And her primary areas of interest comprise diabetes and nutrition epidemiology. She has published extensively on factors leading to the development of diabetes complications, with a special focus on the risk conferred by carrying the haptoglobin 2-2 genotype. She has served in review panels for the American Diabetes Association, the Diabetes UK, the National Institutes of Health, the Rappaport Institute for the Medical Sciences, the Israel Science Foundation, the Royal College of Surgeons in Ireland. And she has also served on the editorial board, or as a section editor for BMC Endocrine Disorders, and on the editorial boards of Diabetes Care and the Journal of Nutrition, as a reviewer for many journals. In 2000, she's a member of the Delta Omega Society, and in 2012, the Department of Nutrition Sciences at Pennsylvania State University recognized her significant contributions to the field of nutrition epidemiology with the Ruth L. Pike Award. And she's also been nominated 3 times for the Craig Award in Teaching at the University of Pittsburgh. And Dr. Costacou is a friend to many of us here, and we just really look forward to hearing her talk. Thank you. Oh, one more similar thing. This seminar was co-sponsored by the Lead Center, and I want to thank Wei for helping me to put this together as well. Thank you, Wei Pern.
Well, thank you so much for both the kind invitation and the kind words. And I'm really sorry I can't be there with you. It really was not. I wish I could have. And I'm trying to get rid of. Wait, I think I need to get rid of the hide floating meeting controls. Okay. So hopefully now you can see the slides in presentation mode.
Yes.
Okay, great, thank you. Okay, so since the publication of the landmark DCCT findings showing that intensive diabetes management reduces the development and progression of complications in type 1 diabetes, there have been significant advances in the healthcare of the type 1 diabetes patient, which have led to decreases in morbidity as well as in mortality in this population, with a consequential rise in life expectancy. So within our Pittsburgh EDC study, life expectancy greatly improved in those diagnosed after 1965 compared with those diagnosed between 1950 and 1964, presumably because most of the most recent diagnosis cohort had most of its type 1 diabetes duration during the modern era of improved type 1 diabetes care. But this improvement in life expectancy of individuals with type 1 diabetes is not restricted to the EDC study cohort. Similar observations have been made in cohorts throughout the United States, but also worldwide. Despite improvements in survival, however, when comparing total mortality and cardiovascular mortality in individuals with type 1 diabetes younger than 45 years of age to those of the general Allegheny County population in the period between 1996 to 2012, total mortality was 5-fold higher in type 1 diabetes compared with the general population. Cardiovascular disease mortality was 33 and 19 times higher in those 30 to 39 and 40 to 44-year-old respectively, and risk was higher in women. Contemporary aggregate data from 6 high-income countries show that despite reductions in absolute all-cause mortality, and as the slide shows, also in some of the SMR, people with type 1 diabetes still have a 2 to 5-fold higher risk of death compared to those without diabetes. Observational data from the Swedish National Diabetes Register also suggests that both all-cause and cardiovascular disease mortality are much higher in type 1 diabetes compared with non-diabetic individuals. So, of course, the question that arises is why? Why do high cardiovascular incidence rates persist in individuals with type 1 diabetes? And perhaps one answer may relate to the fact that the full benefit of intensive therapy, as was shown within DCCT EDIC, has not materialized in the general type 1 diabetes population. So, as mentioned before, the DCCT EDIC study provided definitive data that intensive diabetes therapy leads to significant reductions in the cumulative incidence of cardiovascular disease. Following the publication of the DCCT results in '93, adoption of intensive therapy increased over time within the EDC study population, and it was in fact accompanied by decreases in hemoglobin A1C. Nonetheless, glycemic control remained far from optimal in this cohort, with less than 50% achieving glycemic goals. And this was not just the case within the EDC study. Since the end of DCCT, mean hemoglobin A1C decreased significantly also in the intervention group of the DCCT cohort, trial, remaining around 8% during the EDIC follow-up. But what is more alarming are data that come from the SEARCH study, suggesting that mean hemoglobin A1C in youth with type 1 diabetes today appears to be almost identical to those values that EDC study participants of the same age exhibited in the mid to late 1980s. And data that the updated data that I believe were published earlier this year in Diabetes Care from SEARCH show pretty much exactly the same thing. So, of course, these results raise great concern given the current availability of insulin analogs and diabetes technologies, which allow achieving and maintaining glucose control with fewer episodes of hypoglycemia. So it is clear that suboptimal glucose control is one of the reasons high cardiovascular disease rates persist in type 1 diabetes. To date, glucose lowering in type 1 diabetes continues to rely on insulin use, whereas, of course, we know that for type 2 diabetes, there are multiple therapeutic options. Now, a number of clinical trials have been conducted in type 1 diabetes, which have tested adjunct insulin therapies and have provided some evidence that several of these therapies may reduce hemoglobin A1C, lower A1C, reduce insulin requirements, and therefore, although further data are needed, the use of insulin adjunct therapies may help at some point better manage glucose control, glucose concentrations also in the type 1 diabetes population. But of course, as we know, cardiovascular disease is a multifactorial disease. So it is possible that potentially inappropriately controlled non-glycemic risk factors also have a role to play in these high cardiovascular disease rates in the type 1 diabetes population. Interestingly, DCCT EDIC data suggests that even the effect of glycemia on cardiovascular disease is increasingly mediated by its effect, the effect of glycemia, on traditional risk factors such as blood pressure and lipid levels. Thus, a multifactorial approach may be needed to reduce cardiovascular disease also in type 1 diabetes. And the recent ADA guidelines make specific reference to blood pressure and lipid management. Now, smoking aside, major non-modifiable risk factors and non-glycemic modifiable risk factors include obesity, insulin resistance, hypertension, and dyslipidemia, and we will be addressing the role of each of these factors in the development of cardiovascular disease among individuals with type 1 diabetes. So, of course, I have to have a Greek note in my presentation, so here we go. In the 1st century CE, the Greek physician Areteas described type 1 diabetes as a melting down of the flesh and limbs. Now, we know today that insulin deficiency prevents glucose uptake by cells, leading to the breakdown of fat and muscle for energy, and therefore it leads to a reduction in body weight. And this notion that type 1 diabetes patients are very thin continued through the ages. And there are currently no guidelines relating to obesity for individuals with type 1 diabetes. But is it true that they're still lean? BMI has increased over time, even within the DCCT EDIC study in both the conventional and the intensive therapy group. In fact, within the intensive therapy group, the rate of increase was greater, going from 1% at study entry to 31% at EDIC year 12. This graphic shows BMI trajectories for 100 randomly selected participants of each of the 2 treatment arms from DCCT, as well as a randomly selected sample from the CARDIA study of individuals without diabetes. And it points to steeper increases in BMI over time among those DCCT participants assigned to intensive therapy compared to those assigned to conventional therapy or even the subgroup from CARDIA. Data from the Pittsburgh EDC study also suggest worsening trajectories of BMI over time. Thus, although the prevalence of overweight and obesity was much lower in type 1 diabetes compared with the general enhanced population in the mid to late 1980s, it has now reached similar proportions. Now, we should note here that the increase in BMI had already started before the publication of DCCT results, likely pointing to the fact that this increase in BMI does not relate solely to intensive insulin therapy. And data confirming that the increase in BMI is not merely an aftermath of insulin treatment come from Children's Hospital of Pittsburgh, showing a 3-fold increase in overweight and obesity at the diagnosis of type 1 diabetes between 1980, shown here in the yellow bars, and the 1990s, shown in the blue bars. In addition, the 5-fold increase in overweight and obesity within the same time period among those with confirmed autoimmunity further suggests that this observation is not driven by an increase in the cases of type 2 diabetes. So is this increase in body fatness harmful in type 1? Well, in the EDC study, although it was accompanied by an increased adoption of intensive insulin therapy, updated mean BMI was associated with an increased risk of cardiovascular disease, even after multivariable adjustments. BMI was also shown to be a significant predictor of both all-cause and cardiovascular disease mortality in the FIN-DIAN study. However, a J-shaped association was observed with a nadir BMI being within the normal weight region. In contrast, analyses from the Swedish National Diabetes Registry, in which smokers, those with poor metabolic control, or those with a short follow-up time were excluded to exclude potentially early stages of disease and therefore reverse causality. No increase in the risk of major CVD or cardiovascular mortality was observed with a BMI below 25. A BMI greater than 25, however, was associated with an increased risk of both outcomes studied. Importantly, excess weight gain during the DCCT trial among those assigned to intensive therapy was associated with increased risk of cardiovascular disease. Thus, by the 14th year of follow-up, the cumulative incidence of any cardiovascular event among participants assigned to intensive therapy who gained excessive weight, shown here in the red, with the red line. So the risk was essentially identical to that of participants who had been assigned to conventional therapy, shown in green. So these data clearly show that the benefit of glycemic control can indeed be offset by excessive weight gain. Evidence therefore suggests that the phenotype of the type 1 diabetes patient has changed. There's a higher prevalence of body fatness, both as a result of lifestyle choices, just like in the general population, but also due to intensive insulin therapy. Obesity has been shown to lead to adverse cardiovascular outcomes, even in the context of intensive therapy in people with type 1 diabetes. Nonetheless, there are currently very limited data on weight control strategies in this population. And in fact, weight gain can be difficult to control in this population, especially via exercise, since given challenges associated with managing blood glucose during physical activity. The ACTION Consortium is currently a major ongoing effort to develop weight control strategies while optimizing glycemic control in the type 1 diabetes population. So we'll be anxiously waiting their results. Now, in the general population, obesity, of course, has been associated with numerous metabolic abnormalities, including insulin resistance. And although the mention of insulin resistance in the context of type 1 diabetes may appear surprising, as type 1 diabetes is a disease of insulin deficiency, evidence that insulin resistance affects people with type 1 diabetes has existed since the early 1980s. A recent meta-analysis of 38 hyperinsulinemic euglycemic clump studies in adults suggests decreased insulin sensitivity in type 1 diabetes compared with healthy controls of a similar BMI. However, insulin resistance in type 1 diabetes may appear regardless of obesity status. And I'm sure you're familiar with these data, showing that insulin sensitivity among lean type 1 diabetes adolescents is lower compared with healthy controls, and similar to that of age and Tanner stage matched obese non-diabetic individuals. In type 2 diabetes youth in this study, insulin resistance was accompanied by obesity and dyslipidemia. This was not true for type 1 diabetes youth with insulin resistance. They were not obese and they had lipid concentrations within the normal range, yet they did exhibit impaired exercise capacity and cardiac function. Measuring insulin resistance is, of course, challenging in patients receiving insulin, but researchers have developed regression equations derived from hyperinsulinemic euglycemic clump studies, and the EGDR, it's an estimate of glucose disposal rate, is an estimate of insulin sensitivity developed by the Pittsburgh EDC study group based on clinical factors. And it has been used in a number of studies to predict or to assess whether it predicts vascular disease development. Examples of that include the Pittsburgh EDC study itself, where this estimate of insulin sensitivity was shown to negatively predict the development of coronary artery disease, but also data from the DCCT EDIC study, where again, the EGDR was negatively associated with both cardiovascular disease and any macrovascular disease. And again, these associations were independent of other risk factors. The Cacti study, of course, has also developed an equation to estimate insulin sensitivity, and both the EDC and the Cacti estimates of insulin sensitivity were shown to negatively correlate with the Steno 10-year cardiovascular disease risk score. So insulin resistance is common in type 1 diabetes. It is associated with body fatness, but it can also present among lean patients. Insulin resistance has been shown to predict the development of cardiovascular outcomes in type 1 diabetes. Now, some existing pharmacologic agents have been shown to reduce weight within the type 1 diabetes population. So there is the possibility that they may hold promise in mitigating insulin resistance, even though more research is needed. Moving on to blood pressure, current ADA guidelines for individuals with diabetes are as shown on the slide, have been based on evidence that comes exclusively from middle-aged and older adults with type 2 diabetes. Unfortunately, there are no trial evidence in people with type 1 diabetes, even though hypertension occurs at a much younger age in the type 1 diabetes population, suggesting perhaps that its pathogenesis may differ by diabetes type. Adherence to blood pressure goals, however, has been high in people with type 1 diabetes, as data from the Pittsburgh EDC study follow-up suggest on the slide. Data from Europe, and again, these are data from the National Swedish Diabetes Registry, suggest that although the proportion with hypertension has increased over time, the proportion of patients with hypertension in acceptable control also increased, and therefore blood pressure levels fell over their follow-up period. And as in the general population and as in type 2 diabetes, numerous studies have provided evidence for the important role of high blood pressure in predicting cardiovascular complication development, also in the type 1 diabetes population. So the question is raised as to whether having a similar risk factor profile in the presence of a chronic disease is sufficient to reduce complication risk. Recent data from the EDC study examining the association between time-weighted blood pressure measures and incident CAD pointed to a lower cutoff point as the optimal for predicting CAD incidence. And here a cutoff of 120/80 was seen as the optimal cutoff. Similarly, data from the 10-year follow-up from the Swedish National Diabetes Register also support the notion that systolic blood pressure levels below those recommended by guidelines are associated with the lowest risk for mortality, all-cause mortality, as well as a number of cardiovascular-related outcomes, including acute MI, stroke, and hospitalization for heart failure. And generally, results in this study were similar also for LDL cholesterol. Previous observational studies in type 1 diabetes have also reported that the risk of cardiovascular disease increases at lower blood pressure thresholds than current recommendations. And they have, most of them have pointed to a similarly low cutoff point, so for a systolic blood pressure around 120. So to summarize evidence on hypertension, observational evidence suggests that the optimal blood pressure treatment targets for minimizing cardiovascular risk are lower than current recommendations suggest. And current recommendations are, of course, exclusively based on people with type 2 diabetes. Unfortunately, clinical trial data to guide blood pressure treatment targets, or even the optimal antihypertensive treatment to minimize cardiovascular risk in the type 1 diabetes population continue to be essentially absent. Moving on to lipid concentrations, the ADA guidelines for people with type 1 diabetes are shown here, but once again, these are based on evidence that come from, again, middle-aged or older adults with type 2 diabetes, since once again, there is little trial evidence in people with type 1 diabetes. Adherence to triglyceride goals, however, has again been high in the type 1 diabetes population, as data from the EDC study suggest. Adherence to LDL-C guidelines was high within EDC up until the late 1990s. They fell thereafter, given the change or the lowering of the targets in 2002 and 2005. But generally, individuals with type 1 diabetes have a more favorable lipid profile compared to the general population, especially when under good glycemic control, as data here show from the Costacou study. And this is true, of course, for both men and women. The prevalence of lipid abnormalities as evaluated by traditional lipid risk factors is less prevalent also among adolescents with or youth with type 1 diabetes compared with controls. These are data from the SEARCH Colorado and South Carolina centers. And however, youth with type 1 diabetes do present with atherogenic changes in lipoprotein composition as assessed in this study by apolipoprotein B and LDL particle size. Despite being generally within the normal range, however, lipid concentrations still predict the development of cardiovascular disease in the type 1 diabetes population. These are data from the EDC study suggesting that both HDL cholesterol, which is generally high in type 1 diabetes, as well as non-HDL cholesterol, are significant independent predictors of non-fatal CAD incidence. Similarly, despite being within generally the normal range, both triglycerides and LDL cholesterol are significant independent predictors of cardiovascular disease during the 25-year EDC follow-up. And similar data also come from DCCT-EDIC, where again, both triglycerides and LDL cholesterol appear to significantly predict both any cardiovascular outcomes and MACE specifically. So these data once again raise the question of whether the optimal treatment targets for minimizing cardiovascular risk are lower than the current recommendations for specifically the group of people with type 1 diabetes. EDC data from the 10-year follow-up suggests that the risk of both mortality and coronary artery disease increases at LDL cholesterol levels above 100, and similarly, the increase above triglyceride levels over 100. As already shown, the 10-year follow-up data from the Swedish National Diabetes Register also suggests that the risk of all-cause mortality and the risk of cardiovascular outcomes increases at LDL cholesterol levels below the recommended by those recommended by current guidelines. Furthermore, data from the FINDIAN study also suggests that the current target of 150 milligrams per DL for triglycerides does not predict coronary artery disease among normal albuminuric patients with type 1 diabetes. In contrast, a cutoff of 83, and this was the median in the study, did predict the development of CAD. Despite these evidence, however, there remains a lack of type 1 diabetes specific recommendations, and this is because too few trials have focused on cardiovascular risk reduction in this population. Statins remain the cornerstone of lipid management, and there have been proven to be effective in type 2 diabetes. However, the heart protection study has been the only thus far to include individuals with type 1 diabetes. And although the risk reduction was similar for both diabetes types, it did not reach significance in the type 1 diabetes group, likely because of the small sample size. So to summarize data on lipids, although generally their concentration falls within the recommended levels among individuals with type 1 diabetes, traditional lipids predict the development of cardiovascular disease, raising questions as to whether tighter targets may be more appropriate for the type 1 diabetes population. Now, I would like to turn our attention to non-modifiable cardiovascular disease risk factors, and in particular, genetic risk factors. Although we can't change our genetic makeup, at least not at the moment, genetic analysis focusing on functional polymorphisms especially may lead to the identification of novel targets for therapeutic interventions. So they're important to assess. To date, however, only 2 studies have assessed GWAS in terms of CAD risk prediction in type 1 diabetes. So data are very limited. Associations between SNPs previously identified in the 2 published studies and cardiovascular risk were weak or non-replicable. And furthermore, a CAD polygenic risk score identified in individuals without diabetes and applied to the DCCT EDIC study participants only modestly improved the prediction of cardiovascular disease over standard risk factors. But in contrast, studies have provided consistent evidence for a strong independent association between the haptoglobin 2 allele and cardiovascular outcomes in people with diabetes, both type 1 and type 2. Of course, those of you who know me know of my interest in haptoglobin and are not surprised by the focus. But for those that don't, I'll just take a minute to describe what haptoglobin is and what it does and why I think, at least, it's important. As you may know, approximately 6 to 7 grams of free hemoglobin are released daily into circulation from red blood cell turnover. Free hemoglobin is highly toxic since through release of its heme ion, it has the ability to induce considerable oxidative tissue damage. Well, haptoglobin is the plasma protein that sort of comes to the rescue as it binds free hemoglobin, and via this binding, it inhibits heme ion release, and therefore it reduces free hemoglobin's oxidative potential. The complex, the haptoglobin-hemoglobin complex that is formed through this binding is subsequently rapidly cleared from circulation by attaching to the CD163 receptor on monocytes or macrophages, although a secondary mechanism we'll discuss in a little bit is through the renal proximal tubule cells. This hemoglobin binding property of haptoglobin is crucial for normal physiology. So in addition to its inhibition of heme ion release, this binding reduces the glomerular filtration of both hemoglobin and iron following erythrocyte destruction, therefore protecting the kidney tubular cells from peroxidative injury and also allowing for the recycling of heme iron. In humans, haptoglobin is polymorphic with 2 codominant alleles and 3 major genotypes, haptoglobin 1,1, 2,1, and 2,2. Both structural and functional differences have been described among haptoglobin types, which may be very important in explaining why it's associated with vascular complications of diabetes. So individuals who are homozygous for haptoglobin 1, for the haptoglobin 1 allele, in these individuals, the haptoglobin protein is found as a dimer. Those who are heterozygotes, the haptoglobin protein is found as a linear polymer, and in those who are homozygous for the haptoglobin 2 allele, it's found as a cyclic polymer. The several functional differences, as mentioned, have also been identified between haptoglobin 1 and haptoglobin 2. In general, the haptoglobin 1 protein has been described as a better antioxidant. And this is because it can bind more free hemoglobin, for example, than the other two types. The haptoglobin hemoglobin complex that's formed based on HP11 is more stable, and because of that, it's also more efficient in preventing heme release from the complex, and therefore also oxidation by hemoglobin. It's also more efficient in promoting uptake of the complex by the CD163 receptor, so its half-life in circulation is greatly reduced compared to complexes formed by haptoglobin 2,2. It's a smaller molecule, so it's more effective in sieving into environments where HP22 might be a little too bulky to enter. And given that haptoglobin is an HDL-associated protein, and this is, of course, important when we're describing its effects on cardiovascular disease. So haptoglobin is an HDL-associated protein, but when haptoglobin 2,2 hemoglobin is bound to HDL, it can structurally and functionally modify HDL, given that this complex is redox active. But of course, everyone and everything has a reason for being, and haptoglobin 2 is a better angiogenic factor. The functional differences across haptoglobin types are thought to be exaggerated in people with diabetes, and reasons for that include the proportion of monocytes expressing surface CD163, which is greatly reduced in people with type 1 diabetes, thus increasing the half-life of the complex in this population. There's increased red blood cell turnover in diabetes, which means there's elevated hemoglobin levels and therefore enhanced hemoglobin-based oxidative potential. And lastly, there's increased levels of glycated hemoglobin in people with diabetes. And this is important because although haptoglobin can inhibit more than 90% of LDL oxidation by non-glycated hemoglobin, it can only inhibit about 10% of LDL oxidation by glycated hemoglobin. And these data are thought to explain the fact that haptoglobin 2,2 has been shown to increase coronary artery disease risk only in the presence of diabetes, but not in the general non-diabetic population. Within the disease study, during our 18-year follow-up, we observed that the incidence of CAD increased incrementally with the number of haptoglobin 2 alleles, and it was more than a twofold increased risk, which was independent and significant, associated with the 2,2 genotype. The 2,1 genotype did not significantly increase risks during the 18-year follow-up, but did so when follow-up was extended to 20 years, where both the 2,1 and the 2,2 genotype appeared to significantly increase risk compared with those with the haptoglobin 1,1 group. Similarly, the incidence of significant coronary artery calcification increased incrementally with the number of haptoglobin 2 alleles in the Costacou study. But this was only in the participants with type 1 diabetes. Again, there is no association in controls in individuals without diabetes. Within the DCCT EDIC study, although an overall haptoglobin CAD association was not confirmed, there was, in fact, an increased risk of myocardial infarctions with haptoglobin 2,2, particularly in the secondary intervention cohort, where risk was increased by twofold. Interestingly, within EDC, we had also observed that the risk associated with haptoglobin 2 was more pronounced in individuals with type 1 diabetes and better glycemic control during the EDC study follow-up. And you may ask why. Why would the haptoglobin effect be greater in people under better glycemic control? Well, one reason for that might be that the risk conferred by genetic susceptibility is completely overwhelmed by the effects of dysglycemia in people under poor glycemic control. But an alternative explanation, which I favor, but a lot of my colleagues within DCCT do not, is that in fact intensive therapy does not affect the risk associated with haptoglobin 2,2. And I say this because of data from the DCCT secondary prevention cohort suggesting that intensive therapy lowers the risk of both CAD and MI in the non-HP22 group, but does not affect the risk of either outcome among those who are carriers of the haptoglobin 2,2 genotype. Now, given that kidney disease is a great risk factor for cardiovascular disease, we also wanted to assess the role of haptoglobin in predicting kidney outcomes in people with diabetes. And we used data here from the EDC study. And although there was no association with albuminuria, we did see that the haptoglobin 2,2 genotype was a significant predictor of declining kidney function, as well as progression to end-stage renal disease. And similar data were shown within DCCT EDIC, where haptoglobin 2,2 was a significant predictor of both sustained eGFR less than 60, as well as end-stage renal disease. Now, this discrepancy in the associations of haptoglobin with albuminuria versus kidney function might be a little surprising, but it could be explained by the fact that the renal tubule cells serve as a secondary mechanism for clearance of the haptoglobin-hemoglobin complex. So such clearance is generally only possible for the smaller haptoglobin 1,1 hemoglobin complex. But abnormal glomerular permeability in diabetes may allow larger complexes, such as the haptoglobin 2,2 hemoglobin polymer, to cross the glomerular barrier. But of course, when this happens, in the case of haptoglobin 2,2 hemoglobin, it can lead to oxidative stress, increasing hypertrophy, and leading to impaired kidney function. And we do have some pilot data suggestive of that. So in the presence of albuminuria, there is increased iron deposition in the kidneys among those who have type 1 diabetes and carry the haptoglobin 2,2 genotype. But this is not observed. There's no difference in kidney iron deposition in HP11 carriers by albuminuria status. Finally, given that haptoglobin was a significant predictor of both cardiovascular and kidney outcomes, we wanted to assess whether it also predicts mortality from cardiovascular and kidney complications. And in fact, it was associated with approximately a 60% increased risk of cardiovascular and renal mortality, of course, taking into account competing risks. Now, the importance of haptoglobin really relates to the potential it offers for treatment. Again, haptoglobin is a functional polymorphism, and the associations between haptoglobin 2,2 and vascular complications of diabetes are thought to relate to oxidative stress. So a meta-analysis of three studies in type 2 diabetes showed that supplementation with vitamin E reduced cardiovascular events, but did so only in those who carried the haptoglobin 2 genotype, there was no association in non-HP22 carriers. Unsurprisingly, there are no trial data for people with type 1 diabetes, with the exception of our HAPPY crossover trial conducted here in Pittsburgh using a very small number of individuals. The outcome was not, of course, cardiovascular disease, but rather cholesterol efflux capacity, HDL-mediated cholesterol efflux capacity. And we assessed the effects of vitamin E on HDL-mediated cholesterol efflux capacity by haptoglobin genotype. Interestingly, at study baseline, HDL-mediated efflux, cholesterol efflux, was highest in HP11 carriers and lowest in individuals who carried the haptoglobin 2 genotype. But interestingly, supplementation with vitamin E improved efflux only in the HP22 group, but it did not affect efflux in the other two groups. So in summary of what we've just discussed, although there have been great strides in the healthcare of the type 1 diabetes patient, and they have led to increases in life expectancy, cardiovascular complication rates remain high in this population. Suboptimal glucose control certainly explains some of this risk, but evidence suggests that the optimal lipid and blood pressure treatment targets for minimizing cardiovascular risk appear lower than current recommendations, which are exclusively based on individuals with type 2 diabetes. So there is a need for trials assessing the impact of cardiovascular risk reduction strategies, specifically in the type 1 diabetes population. Potential medications which have been shown to be effective at slowing the progression of kidney disease, reducing heart failure, and lowering the risk of death among individuals with type 2 diabetes should also be evaluated in the type 1 diabetes population, and perhaps they may offer great benefit. Now, I discussed data on the effect of haptoglobin on CAD and prior data for a protective effect of vitamin E supplementation on cardiovascular risk reduction only in the genetically susceptible group carrying the haptoglobin 2 genotype. These data suggest that precision medicine approaches are needed to identify subgroups who may benefit from specific interventions. So although my interest is in haptoglobin, this was just an example of how similar analyses, regardless of a genetic susceptibility, could be other factors, might lead us to identify risk factors and or specific interventions that would benefit subgroups of the population, if not the entire population of people with type 1. The ADA and the European Association for the Study of Diabetes have instituted a joint precision medicine and diabetes initiative to promote research and hopefully ultimately clinical implementation of precision medicine. And we'll see what they come up with. So in conclusion, to mitigate cardiovascular disease risk in the type 1 diabetes population, in addition to continuing efforts to control glycemia, attention should also focus on other cardiovascular risk factors. Type 1 diabetes specific guidelines and clinical targets for risk factors such as obesity, physical activity, lipids, and blood pressure should be developed, as currently their absence is a limiting factor in mitigating cardiovascular disease in people with type 1 diabetes. So thank you very much for your attention, and I'd be happy to entertain any questions.
Thank you, Tina. Does anyone have any questions for her? If not, I'll go first then. So my first question was, have you looked at the haptoglobin genotype with stroke?
Yes, yes, we have. And in fact, the association, there was no time to go into that, but in fact, for stroke, there was a positive association between the one allele, not the two, the one allele, and stroke incidence in people with hypertension.
Okay.
So this is a little complicated. This is what we have seen, and in fact, studies in the general population have also seen that a greater prevalence of the haptoglobin 1 allele among stroke patients. So this appears to be regardless of type 1 diabetes status. But now there's confusing evidence, because at ADA, I was talking with Perry from FinDian, and they do not see the same association. So I'm not quite sure what to say anymore. I thought that it may have been relating, but yeah, so I'm not sure. I think we need more data on this to figure out exactly what is going on.
And so what does that particular allele do?
Haptoglobin 1?
Yeah.
Well, it's supposed to be a greater anti-inflammatory and antioxidative factor. But on the other hand, I think I may have mentioned it, I can't remember. Haptoglobin 2 is a greater angiogenic factor. So, yeah. So if you think about it, if you're having a stroke, perhaps haptoglobin 2 might be of benefit if it's a better angiogenic factor. But those were my hypotheses at the time. Now with the data from the FinDian study, which is a huge study, suggesting that there is no association between haptoglobin 1 and increased risk of stroke, then I think we have to revisit. Because again, our data were, I believe, only in the post-65 diagnosis cohort and only among individuals with hypertension. So there's the sample size was very small, is what I'm trying to say.
Okay. Thank you. Are there any other questions?
Yeah, hi Tina, nice to see you.
Hi, Dana.
Very nice presentation, and I'm so sorry you couldn't be here. Maybe next time. Yeah, I may want to take you in a slightly different direction.
Okay.
I was struck by the comparison in average hemoglobin A1C in youth with diabetes today from SURGE and DCCT 30 years ago. Now, obviously, we would have expected, better glycemic control with such progress in technology and treatment opportunities. And you've used that nicely to provide the rationale for going into, biologic cardiovascular risk factor profiles, et cetera. But one thing that I think we're not paying enough attention when we do such comparisons is that 20, 30 years ago, type 1 diabetes was a disease of non-Hispanic whites.
Yes, you're right.
The vast majority of patients were white, wealthy, educated. Now, type 1 diabetes is increasing more so in other ethnic groups than whites. And so I'm wondering to what extent what we are seeing today with glycemic control should make us think about, in addition to the things that you've described, about more social structural determinants of cardiovascular health in a totally different population that we have today as compared to 20 years ago.
Absolutely.
And how do we integrate this precision medicine approach with some things that might be needed at a larger scale that simply would bring people who are not even treated with pumps or who can't do CGM were not screened for lipids and blood pressure to at least the level that we are talking about in your presentation today.
Yeah, absolutely. I mean, there's some very basic things, right? Like health insurance is a pretty basic thing. And if you can't afford to take care of yourself, clearly, that will affect, and you have type 1 diabetes, it will affect your glucose levels, it will affect your outcomes in terms of vascular disease further down the road. Of course, yes, you're absolutely right. Absolutely.
So how do we combine precision medicine with?
Yeah, I think social factors can be part of a precision medicine approach. I don't see why they would need to be separate. You know, when you're looking at precision medicine, you're not, again, grouping, you're not looking at the entire population, you're trying to look at individual characteristics. So you should be taking into account the social construct and, you know, how people are coming to the outcomes they're experiencing, and how do we do better. But I think, I mean, it's wonderful to talk about these, like us talking about these things, but the issue is what can be done at the end of the day. We do know that clearly there's social factors that affect health, period, regardless of whether you have type 1 diabetes, right? And we've known that for a very long time. But unfortunately, I don't see us changing. I mean, there's, maybe I should not go into this. Especially
It's okay.
given,
It's okay.
Even the, tomorrow is election day, and I don't want to go into something that's going to get me in trouble. But
I have a non-election day question. So I really liked your slides on HDL cholesterol mediated efflux, and familiar with that work. That's great. This is really, the question actually relates to the type of obesity related to intensive therapy, but the real question relates to subclasses of HDL and mechanisms for potential mechanisms for cardiovascular disease risk. So Karin Bornfeld published in JCI, really nice paper that actually the cacti study is included in, and it included mouse studies and population studies that nicely showed that HDL ApoC3 subclass is mechanistically associated with the increase in cardiovascular disease in mice, and that subclass, and Greg did the analysis on the shotgun proteomics of that work, showing that the HDL ApoC3 class specifically was related to cardiovascular. I'm not sure if it's cardiovascular disease or coronary calcium right now, but an increase in coronary risk in the cacti study. Also, with the intensive therapy in the follow-up from the DCC, Nicole Carlson showed that the trajectories between the intensive and regular therapy, actually family history of type 2 diabetes, predicted differences in those trajectories. So what do we know about the obesity, the insulin resistance related to the therapy in type 1, and is HDL-mediated ApoC3 cholesterol efflux a potential target for this specific risk, if you wanted to talk about personalized medicine?
Yeah, I don't have data. In fact, okay, so to be out in the open, I have a grant. I had a grant on HDL subclasses and CAD using EDC samples, and I am supposed to be. I'm working with Jay Heineke and Karen Bornfeld and Thomas Vazar. They have. We're still waiting for data. on proteomics and ApoC3. They have not provided to us. The grant's over. We're still waiting. What we have seen, again, I can't comment on ApoC3 because we don't necessarily have those data for the EDC study population. But I can tell you that in terms of HDL subfractions, we do see that there are associations with the development of CAD, but those differ by sex. There are very strong associations in men, but there are significant associations in women. However, they're not that strong. The confidence intervals are marginal.
Is the sex differential mediated by HDL? That's actually interesting. I'm not surprised, but that's an interesting observation.
We have not been able to publish the data. We're still waiting for Jay to write comments. It doesn't appear. I'm sorry, what was the question? Is the difference?
I'm wondering about the nature of the obesity related to the intensive therapy, because all of these things would imply, regardless of the fact that the type 1 diabetic is lean, if they have more intra-abdominal fat, you might predict some of these effects. So it might not be overall BMI effects, but specific depots. Right.
So in our analysis, at least, we have taken into account BMI and also hemoglobin A1C. At the time, I don't think any of our participants were really very intensively treated, to be honest. So I don't know that we would be the right group to provide those answers.
Great, thanks. Great talk and great to see you. I would like to say great to see you in Colorado, but just great to see you anyway.
Thank you.
Great to see you, John. John, great to see you too. We haven't seen you in a long time.
Well, it's great for me to see all of you because I haven't seen you all in a very long time.
Well, thank you so much, Tina. Jill said, well, she actually left right at the end of the presentation, but she said she really enjoyed the seminar. It was wonderful. And someone else said, iPhone user said, thank you for an excellent presentation. Learned a lot from the presentation. Can we have the slides? Anyway, I just want to thank you so much. You did a great job. And I was going to tell you privately, but I loved your font and the way you put your slides together. So the background. Yeah.
Thank you very much. Blushing.
See you.
Agreed.
Bye-bye.
Bye.